We have the pleasure today of welcoming Dr. Ann Peery, who is an associate professor of medicine at the University of North Carolina at Chapel Hill. She is a gastroenterologist and funded clinical researcher. Her research focuses on understudied but common gastrointestinal diseases with a particular focus on diverticulitis. Welcome, Dr. Ann Peery.
Thank you. I appreciate the opportunity to talk today. So I have for you just a really practical talk on caring for patients with diverticulitis. And I titled the talk Tick, Tick, Boom, because a lot of times when I see these patients in clinic, they come to me telling me that they've been told they're a ticking time bomb and that something catastrophic is going to happen. So that's what I want to really focus on today. So I'm going to start with a case. This is a woman that I saw just a couple of weeks ago in clinic. She's 60 years old. She has a history of multiply recurrent, acute, uncomplicated diverticulitis, and she came to clinic after she had had yet another episode. Her acute pain when she had the episode was disabling, but her symptoms were now resolved. So sitting with me in clinic, she had no symptoms. She felt much better. She was otherwise healthy. She took no medications. And on the exam, her abdomen was non-tender, but she was tearful. If anything, she was just really distraught. So my patient had the following concerns. She was quite afraid that she would have another episode, and that next episode would be just catastrophic, that she would develop a perforation or an abscess. She was afraid to eat. She wouldn't eat out. She'd only eat the things that she prepared because she was afraid that if she ate the wrong thing, it would cause another episode of diverticulitis. She didn't want to take antibiotics anymore because if she felt like when she took the antibiotics, they just made her feel worse. She was also afraid of surgery. She was afraid that if she had surgery, she might end up with a permanent ostomy. She was afraid that if she had surgery, that she might even have more diverticulitis after the surgery and that the surgery would be all for naught. She was also quite afraid of what might be found during surgery. And so in my practice, seeing patients with diverticulitis, these are the common concerns that I hear. And I want to walk you through how I addressed her concerns a couple of weeks ago in clinic. So to start, we should talk about how diverticulitis presents. The classic presentation of diverticulitis is acute onset left lower quadrant pain, a fever, and a weight count. That's the classic presentation. But what you need to know is that many patients with diverticulitis will never have a fever. They may not even have a weight count. The pain may not be in the left lower quadrant. And so when I saw this patient a couple of weeks ago in clinic, she had seen her primary care doctor the week prior. And when he saw her, he said, well, you don't have a fever, so I don't think you have diverticulitis. I don't know what's going on, but this isn't diverticulitis. So we should all understand that clinical suspicion of diverticulitis alone, it's correct in only 40 to 65% of patients, which means that to make a diagnosis of diverticulitis, you really need imaging. It's very difficult to make a diagnosis of diverticulitis based just on history and physical alone. And as we all know, the differential diagnosis for acute onset abdominal pain is quite broad, with many potential pathologies, all of which have a very different management. Unfortunately, there are no useful decision tools to make a diagnosis of diverticulitis without imaging. And there have been several studies that have attempted to develop a decision tool based on labs and physical findings, but they just don't work. So you really need to consider getting a CT scan to confirm a diagnosis in patients without prior imaging. You also want to get a CT scan in patients who have a more severe presentation. You want to rule out an abscess or a perforation or some other complication. You also should consider getting a CT scan in patients who have worsening or ongoing symptoms after an initial diagnosis of acute uncomplicated diverticulitis. And I want you to understand why you want to get a CT scan in patients with worsening or ongoing symptoms. So everyone should understand that after an initial diagnosis of acute uncomplicated diverticulitis, about 5% of patients will get worse. About 5% of patients within 3 months will go on to develop a complication. And then if a patient with uncomplicated diverticulitis, if they're going to get worse, the most common complication that they're going to develop is an obstruction, and it's usually within 10 days of diagnosis. You should also know that among patients diagnosed with acute uncomplicated diverticulitis, maybe 6% within 6 months of follow-up will go on to have smoldering diverticulitis. So smoldering diverticulitis is also sometimes called chronic diverticulitis by the radiologists. Smoldering diverticulitis is inflammation that persists for weeks to months. And this can be captured on imaging. And these patients may start to get better with a course of antibiotics, but then they complete the course of antibiotics and their inflammation returns. It's also important to know that many patients who have experienced acute uncomplicated diverticulitis, they have ongoing chronic symptoms. So in one trial, 45% of patients at 1 year follow-up after initial diagnosis of uncomplicated diverticulitis, they reported ongoing discomfort. And in my practice, those patients with ongoing discomfort, it's usually much more mild than the initial episode, but it's an awareness of usually their colon that they never experienced before the diagnosis. Know that colon cancer can mimic diverticulitis on CT scan. So imaging isn't perfect. It's important to make a diagnosis, but it isn't perfect. So we know that about 1% of patients who initially have a diagnosis of acute uncomplicated diverticulitis, they'll be found to have a colon cancer on follow-up colonoscopy. The risk of a missed cancer is higher in patients with a history of complicated diverticulitis, and we think that risk is about 8%. So about 8% of patients who initially have a diagnosis of complicated diverticulitis, they'll be found to have a colon cancer on follow-up colonoscopy. So you really should consider performing colonoscopy after any episode of complicated diverticulitis. You want to consider getting a colonoscopy after a first episode of acute uncomplicated diverticulitis, unless the patient's had a high-quality exam in the last year. Know that patients with recurrent uncomplicated diverticulitis, they do not have an increased risk of colon cancer. So after that baseline screening exam, those patients with recurrent uncomplicated diverticulitis, they really just need to follow routine screening and surveillance intervals. So getting back to my patient's concerns, she was afraid of what might be found during surgery. And she was afraid of what might be found during surgery because her primary care physician he'd questioned the diagnosis. But what I told her was, look, you have had 3 prior episodes confirmed by CT scan. Your most recent episode was just like prior. You're up to date with screening colonoscopies, and she had no alarm symptoms. So I told her, look, I'm really quite confident that this is recurrent diverticulitis. And hearing that, I think, was incredibly meaningful to her. So let's talk about her fear of having another episode and her risk of abdominal catastrophe. So it's really important to understand the natural history of diverticulitis. We tend to think of it as this acute self-limited disease. But for some patients, it can become multiply recurrent and more of a chronic condition for them. So after a first episode of diverticulitis, the risk of second episode or recurrence is about 17% in 5 years. And after a second episode of diverticulitis, the risk of a third episode is about 44% in 5 years. In other words, the risk of recurrence increases with every recurrence. We don't have great estimates of recurrence after the third or fourth episode. But what I generally tell patients in clinic is, look, once they've had 3 or 4 episodes, they are most likely to continue to experience recurrences. So patients with recurrent diverticulitis, they worry that they're at increased risk of developing an abscess or a perforation. Many of them have actually been told that they're at increased risk for developing an abscess or perforation. It's really important that we educate patients that recurrent diverticulitis is not a risk factor for abscess or perforation. So big picture, if you had 100 patients with diverticulitis, only 12% of them will develop an abscess or will develop a complication. So among patients with diverticulitis, the risk of a complication is about 12%. And if a patient is going to develop a complication, it's usually an abscess or perforation. Know that diverticulitis can also lead to strictures and fistulizing disease. But if a patient is going to develop a complication, and again, the most common complication is abscess or perforation, it is usually the very first presentation of diverticulitis. So this is population-based data from the United States. On the y-axis, you have number of complicated diverticulitis cases. On the x-axis, you have antecedent or prior episodes of diverticulitis. And what you can see is there's that huge bar on the left, right? 286 cases. So most of these patients who were presenting with complicated diverticulitis, it was their very first presentation of diverticulitis. So I had told my patient, look, you will most likely continue to experience recurrent episodes of diverticulitis, but you are very unlikely to develop an abdominal catastrophe like abscess or perforation. So what about her fear of eating? It is important to know that many patients with diverticulitis, they attribute all of the risk of diverticulitis to what they've eaten. Many of them blame themselves for this disease and they're afraid to eat. And what patients need to understand is that there are multiple risk factors for diverticulitis. There is some contribution of diet, but you've got to put it into perspective. So to start, age and sex are risk factors. This is incidence or risk of diverticulitis in the United States by age groups and sex. And what you can see just eyeballing this figure here is that the risk of diverticulitis, it increases with age. Interestingly, before the age of 60, men in blue are more likely to experience diverticulitis compared to women in yellow. After the age of 60, women in yellow are more likely to experience diverticulitis compared to men. The reason for this disparity is unknown. So beyond age and sex, there are several modifiable risk factors for diverticulitis. Physical inactivity and obesity are important risk factors, so is smoking. A Western diet is also a risk factor, and in the studies of diet, it looks like high red meat intake and a low fiber diet really contribute to the risk. But that contribution of risk is maybe 15, 20% at most. Regular use of NSAIDs, non-steroidals, those are also risk factors for diverticulitis. And in my practice, I have many patients who come to me with diverticulitis who are not obese, they don't smoke, they consume a healthy, balanced diet, they're physically active. And I think it's important that all patients, particularly the ones who are already really health conscious, understand is that there's this really genetic component to diverticulitis. So we know from a couple of European population-based studies that about 50% of diverticulitis risk is due to genetic factors. And we also know from a handful of genome-wide association studies that genes that play a role in paired neuromuscular function in connective tissues, those are associated with diverticulosis. And that genes that play a role in epithelial dysfunction, those play a role in diverticulitis. Know that nut, corn, popcorn intake, they do not increase the risk of diverticulitis. So patients, they certainly don't need to avoid these food types. Constipation is also not a risk factor for diverticulitis. And so when I see patients in clinic and they want to talk about modifiable risk factors, I usually recommend that they maintain or achieve a healthy body mass index, that they avoid NSAIDs, that they consume a healthy diet, avoid red meats, sweets, fried foods, high-fat dairy, that they not smoke, and that they're physically active. So another one of my patient's concerns was that she didn't want to take antibiotics. She felt like whenever she took a course of antibiotics that there were just new and worse symptoms just from taking the antibiotics on top of the episode of diverticulitis. And what I told her is, look, there have been a handful of randomized trials looking at antibiotics compared to no antibiotics in patients who have CT-confirmed acute uncomplicated diverticulitis. All these trials were performed in Europe, and what they found is that there was no difference in time to resolution. In other words, it didn't matter whether or not patients got antibiotics. Antibiotics did not expedite the recovery from the acute episode. And in those trials, they also found there's no difference in the risk of going on to develop complicated diverticulitis. So now multiple guidelines, both in Europe and now American, recommend that antibiotic treatment be used selectively rather than routinely in immunocompetent patients who have mild, uncomplicated diverticulitis. So we can be antibiotic sparing in patients who have uncomplicated diverticulitis. That is mild in patients who are immunocompetent. You do want to use antibiotics in patients with significant comorbidities, those who are frail. You will always treat patients who are immunocompromised with antibiotics. Patients who have refractory symptoms, smoldering or chronic diverticulitis, you want to treat them with antibiotics. Vomiting is a bad sign. They should be treated with antibiotics. Any patient with evidence of SIRS, an elevated white count, elevated CRP, unstable vital signs, they should all be treated with antibiotics. And certainly any patient with diverticulitis that is significant enough to be hospitalized should be treated with antibiotics. So outpatient diverticulitis, it's most commonly treated with a combination of metronidazole and of fluoroquinolone. We've done a couple of studies here at UNC that found that amoxicillin clavuline is a good alternative to a combination of metronidazole with fluoroquinolone. So for my patient in particular in clinic, it was the metronidazole that she had pretty significant symptoms from. So augmentin is a good alternative. Be really cautious when you take care of patients who are immunocompromised and have diverticulitis. They have an increased risk of complications and actually mortality from diverticulitis. Their pain can be a lot less severe, and it can be really disproportionate to the amount of inflammation that they have. So I always have a low threshold to get imaging because they can have an abscess and you won't know it, to treat them with antibiotics and to even get a surgical consult. So what about my patient's fear of surgery? She had had a primary care physician and she felt like she was being actually pressured into having an elective resection to prevent more episodes, but she was really quite afraid of even considering surgery. So patients often want to do something to prevent more episodes. Unfortunately, there are no medical therapies to prevent recurrent diverticulitis. There have actually been several trials of mesalamine to reduce the risk of recurrence, and it doesn't work. So don't treat with mesalamine to reduce the risk of recurrence. Probiotics and rifaximin also don't work, so we shouldn't do that. An elective resection of the colon, it's an option, but it really needs to be a patient-centered decision. Years ago, we would count episodes, and after the second episode, we'd say, yep, it's time to have a resection because you might perforate, but again, that was wrong. So there are a few things that patients should really understand if they are going to consider an elective segmental resection. The first is we have data from a couple of small trials that patients who undergo an elective resection for recurrent diverticulitis, about 70%, will have an improvement in their quality of life. And really, quality of life is the reason to consider surgery if they're going to do it. But again, when you look at that statistic, it means that not everybody improves. And so we want to think about who those patients are that don't get better with an elective resection, who don't have that improvement in quality of life. And so there are a few things that patients should know. The first is that there is a risk of recurrent diverticulitis after an elective segmental resection. And there's recent data that suggests that about 15% of patients who've had a resection for diverticulitis will go on to have recurrent diverticulitis. There's also a risk of new bowel symptoms, incontinence, constipation, urgency. We think that risk is maybe 20% after an elective resection. This isn't as well studied, and I think is a really important factor that patients need to be aware of, that even if you remove a small segment of colon, they may develop new symptoms. It's also really important to be cautious in those patients who have ongoing symptoms, in particular pain with no evidence of inflammation after an episode of diverticulitis. There are a couple of studies that suggest that those patients who have an elective resection for ongoing symptoms, that many of them continue to experience those symptoms after surgery. And the thought there is that their pain is driven more by visceral hypersensitivity than ongoing inflammation. It's also important that patients understand that there is a small risk of an ostomy being created after an elective resection for diverticulitis. And data from the VA, an ostomy was created in 10 to 18% of patients undergoing elective resection, and only 50% of patients underwent takedown surgery. I think this estimate is quite high, and I think as long as the correct patient is chosen and they go to the right surgeon, I think that risk is a lot smaller. So in conclusion, I think it's really important that you make a confident and specific diagnosis of diverticulitis. It guides treatment. And from the patient perspective, they really need to hear from us that we're confident in the diagnosis, or else many of them really, they worry that there's something else going on and we're just not telling them, and that perhaps they have a missed cancer. Be sure to educate your patient on all risk factors. It's not just diet. And what is their prognosis? Talk to them about the natural history of diverticulitis. They need to understand that they're not a ticking time bomb, that their risk of abdominal catastrophe is very low. It's okay to treat with antibiotics selectively. I think this makes a lot of providers uncomfortable, but we have data to support this decision, and multiple guidelines now do suggest that antibiotics be used selectively. And when you discuss elective surgery for recurrent diverticulitis, really focus on patient preference and hear out your patient and talk to them about that decision. Here are a couple of references for this talk. We recently published a clinical practice update on diverticulitis and gastroenterology. The ACP, the American College of Physicians, just published 2 guidelines on management of diverticulitis in the annals. And those are a great reference for taking care of the patients. And with that, I am happy to take any questions.
Really interesting practical talk. I'm Allie. I'm one of the recent graduates of the fellowship program. One question for those patients who you're not going to give antibiotics or are having an acute episode, other than telling them it will probably get better in a couple of days, is there anything else you recommend to them to, hasten their symptom relief? That's one question. And the other question is, what do you do with those patients with the chronic pain, which is probably some visceral hypersensitivity? Do you start treating like an IBS situation? What do you do for that situation?
Those are great questions. So first, for the patients who have ongoing symptoms after an episode of diverticulitis, one, I usually make sure they've had a colonoscopy and that they're up to date with screening. 2, I usually repeat imaging to make sure there isn't something else going on. And then for a lot of them, honestly, in my practice, it's not severe pain. It's usually like an awareness in their abdomen of where they had diverticulitis, and they're just worried. And they just want someone to tell them that it's not in their head and that they shouldn't be feeling better, because a lot of them have seen their primary care doctor and they're like, well, you should be better by now. And they're like, no, I still feel it. Like I still feel that area. And so the majority of them just need like confident reassurance. I've had some who have more severe pain, and I take like a post-infectious approach to them, and I treat it like visceral hypersensitivity. And I've had great success in using TCAs and SNRIs. Like it's very Doug Drossman. I love it. They do really well. And then I think your other question was about how do you manage patients with like an antibiotic sparing approach. I sort of have 2 buckets of patients. I have one one group of patients who like really embrace antibiotic sparing. They love it. They don't want to take antibiotics. And I think that's totally reasonable as long as it's a mild episode. My patients tell me, and I don't know how to feel about this, they tell me that they feel better if they go into a clear liquid diet for a couple of days. And then they slowly liberalize their diet. And I think as long as it's a couple of days, that's fine. And a lot of them do really well. Now, I do have patients who feel very strongly that they have a course of antibiotics. And for those patients, I usually do write them for antibiotics if they feel strongly, because I don't want them to end up in the ER or to do something unnecessary. So.
And Jim Marion in the conference room, that was an excellent talk. I really admire the pragmatic approach that you're advocating for this. But this is Mount Sinai. So I remember in the 1990s when I was a fellow, some of the old timers, Henry Janowitz and Danny Present would say things like, well, diverticulitis of the sigmoid resembles Crohn's disease in many ways, and they were treating them with sulfasalazine going back to the 1940s and 50s. No, I see you shaking your head, but yeah. They really drilled it into us because, when you're at Mount Sinai and you're a hammer, all the world's a nail type of thing. So my question to you is, we often see a fair amount of diverticular associated colitis, which, again, sort of, because we're a center and people refer them here, how often are you encountering that type of genuine, typically sigmoid segmental colitis in the setting of diverticulosis in your clinic? Yeah, and how do you manage that?
Yeah, no, that's a great question. And so your question is with regards to SCAD.
Yeah.
Segmental colitis associated with diverticular disease or diverticulosis, SCAD. And I don't, from my perspective, SCAD is in the spectrum of diverticular diseases, but is unrelated to diverticulitis. So you don't have to have ever had diverticulitis to develop SCAD. I think of it as its own pathology. And I've certainly seen several patients with SCAD. And I know that in our IBD center, they also see a number of patients with SCAD. And SCAD should be peridiverticular inflammation that spares the rectum. These patients really should have GI symptoms. It shouldn't be an incidental finding for the most part. And the pathology, the histopathology should be chronic colitis. I think those patients have a better prognosis than a patient with IBD. We do treat them. We absolutely treat them with mesalamine. About half of my patients who have gone on to have a formal diagnosis of IBD. So I follow them closely. I give them a lot of attention because I don't know which way it's going to go. Is it going to be a rather benign course and just respond to mesalamine, or are they going to need more intensive therapy? Because sometimes they do. Mm-hmm.
Hi, actually, I have a follow-up question. Thank you so much for this talk. It was very, very practical. I'm one of the GI fellows here. Are there any instances in which you think it'd be appropriate to manage patients with long-term antibiotics? For example, here we often have pouch patients who ended up getting an IPA for UC, and we sometimes put them on long-term Cipro for recurrent pouchitis. Are there any instances where patients should be on, fluoroquinolone and metronidazole for refractory or persistent diverticulitis, or at that point, is that when we should be talking about surgical resection?
Yeah, that's a great question. I have had a few patients who had smoldering diverticulitis, and that was inflammation that I could capture on CT scans over a series of weeks. And they also had ongoing symptoms. So it wasn't just an incidental finding. It was inflammation on CT. They had pain. They were symptomatic. And I've had patients respond to a longer course of antibiotics. I had one woman on Augmentin for about a month. And she did respond, and she did not need surgery. I think if you're going to need to treat much longer than that, they probably do need to consult with a surgeon.
Thank you. So more than a month, we should be involving surgery.
That's a hard question. I think when you're considering surgery, it is worth trying a more prolonged course. It's when you try and stop the antibiotics and the inflammation comes back, or if the inflammation doesn't respond at all, then you certainly need to consult with a good colorectal surgeon.
Hi, this is Alana Mazer. Great talk. You said that a lot of patients have, you use imaging a lot because patients don't always present with fever and white count, but we have an abundance of patients as gastroenterologists with IBS and left lower quadrant pain and right upper quadrant pain. When do you say, okay, I'm going to do the imaging? Is there something that sort of tips you over and says, this is different? I mean, also a lot of the time we're seeing them for the first time. So, do you try them on, treatment for constipation first? What makes you say, oh, I better image this patient in the absence of the obvious fever and white count?
Right. And I think the symptoms of IBS are so different than the symptoms of constipation versus the symptoms of diverticulitis. And I do try and go back and review prior imaging and take a good history. I think it's often in the history where you can make sort of the diagnosis enough to decide, do they need new imaging? I'm thinking. I do think it's really important to review prior imaging. I've had a couple of patients come in and their history didn't sound quite right. And then I looked at the old scans and they clearly, they didn't have diverticulitis. They had constipation and their symptoms fit, or I've had a couple of ischemic colitis patients. And I don't know why, they were told they had diverticulitis. If I need to, I will repeat imaging. I do think it's important to make the right diagnosis. And it can be tricky, but I don't check a fecal calprotectin. I don't check non-specific inflammatory markers because it's not helpful.
Thank you.
Hey, Dr. Peery, this is Teaching Nugul. I'm one of the GI attendings here in the Fellowship Director. I just wanted to thank you for a fantastic talk. I just want to see if there are any other questions before we close out. All right, great. Thank you again. Really appreciate it.
Thanks for the great questions.
Thank you.